Assalamu alaikum. On behalf of Ahsan Academy, let me welcome you to a presentation on Scalp. This presentation will include a brief description of the scalp, its structure, and various supplies as well as drainage of the scalp. At every stage, we will correlate clinically. This is the diagram of a scalp. You can see the level area. This is an elevated curved area just above the supraorbital margin, and it is known as supraorbital arch. If we draw a line and take it down to the zygomatic arch, and if we draw that line behind over the external acoustic meatus along the supramastoid crest, and then extend the line, and you can see the red line. It is the supreme nuchal line or highest nuchal line. Then we'll get a continuous line. The part above this line, the skull, is covered by a very important layer. This is known as scalp. So in some case, you see this is the diagram showing the scalp, and this is the hairline. We can say in this hairline can be identified even a person with a board. And actually the part between the supraorbital arch and the hairline is identified as forehead. In some cases, the forehead is excluded from the scalp. In that case, I have drawn another red line to show the extension of the scalp. The scalp has 5 layers from outside to inside. You can identify them by the spelling letters that required to spell scalp. So S indicates skin, then C is the connective tissue, A is the aponeurosis of occipitofrontalis muscle, and L means loose connective tissue, and finally the innermost layer is the pericranium. So we can easily remember the layers of the scalp from outside inward. Let us discuss one by one. The skin is hairy and contains many hair follicles in it. Sometimes the hair content may be less, but hair follicles will find numerous in the scalp. And the scalp skin is rich with the sebaceous gland and also contains sweat glands. This is indicating the sebaceous gland, and it is opening into the hair follicle. You can easily see, and a duct you can see this opening into the surface is the duct of the sweat gland. The second layer from the outside is the connective tissue layer, and it is a fatty tissue. It is lying between the skin and aponeurosis, and it is traversed. This fatty tissue is traversed by many fibrous septum. That's why it is known as fibrofatty layer. So the fibrofatty layer between the skin and aponeurosis is the second layer. It is very vascular and shows profuse anastomosis between the vessels. And these vessels wall are very intimately related to this fibrous septum. This numerous arteries and veins, they makes a free anastomosis with each other. So if the surface is scarred, then a small cut will cause severe bleeding, profuse bleeding. And if the injury is such that there is no surface cut, then bleeding will spread, and there will be a swelling in this area, which is very firm and localized. You can see this is the swelling here. There are numerous sebaceous glands, so there may be chance of more sebaceous cyst in the skull region, and all the conditions are painful because it is having many nerve supply. And emissary veins are the small veins that connects the veins outside the skull with the veins inside the skull. So these veins are not having any valves, and that's why it allows the flow of the blood in either directions. This is very important in this respect that it can physiologically it can equalize the pressure inside the skull with the outside. So if the intracranial pressure is increased, some amount of the blood comes out to reduce the pressure, ease the pressure actually. And if the temperature of the intracranial vein rises, then some part of the venous blood comes out and become cool and returns back to the vein, intracranial vein, to reduce the temperature. Pathological importance is that bad elements can flow from outside to inside, creating severe condition. This is the emissary vein. You can scalp injury causes severe profuse bleeding. Why? It's a very vascular and having blood vessels having numerous anastomosis between them, and the blood vessels are attached to the fibrous septum of the dense connective tissue. So when the blood vessels are cut or injured, this attached fibrous tissue prevents the spasm, contraction of the blood vessels, so there is profuse bleeding from the injury. The third layer from the outside is the aponeurotic layer, and it is actually the occipitofrontalis muscle. The occipitofrontalis muscle has an anterior belly, or this is known as frontal belly of the occipitofrontalis muscle, and it remains anteriorly attached to the skin over the forehead, superficial fascia of that region, and the eyebrow muscles. Posteriorly, the belly is known as occipital belly of the muscle, and it is having the bony attachment to the highest nuchal line of the occipital bone. This red arrow is indicating the line on the back of the skull. In between the muscle, the mid part is connecting the two muscles, and it is the common aponeurosis. This common aponeurosis extends anteriorly to the front belly and posteriorly to the occipital belly, and in between this is continuous, and on either side it is fuses with the temporal fascia, continues with that fascia, but remain attached to the superior temporal line of the skull of the bone. So this bone is this muscle actually, occipitofrontalis muscle is attached posteriorly to the bone, attached side laterally to the bone, but it is not having any attachment anteriorly, any bony attachment anteriorly. Glea poneurotica is a terminology used to indicate these three layers. You see superficial three layers of this. The aponeurosis is tightly adherent to the connective tissue by some tough fibers, and this is fibers are continuous with the aponeurosis and muscles of the occipitofrontalis muscle, and these together known as glea aponeurotica because this moves together. This is the glea aponeurotica shown in the diagram, and these upper three layers, especially the aponeurosis and the connective tissue, moves together. They can slide over the underlying loose connective tissue, who forms the fourth layer of the skull. You can see this fourth layer is the loose areolar tissue, and it is separating the aponeurosis from the periosteum of the skull. A few blood vessels are observed here. The main blood vessels remain in the second layer of the skull from outside. You see, you have observed that occipitofrontalis muscle has attachment posteriorly and bony attachment on either side, but no bony attachment anteriorly. So the blood vessels are remaining in the layer, loose connective tissue layer, deep to the aponeurotic layer. If injured, that blood cannot come out because of this intact outer layer. So this spreads along the loose connective tissue layer deep to the occipitofrontalis muscle, and we have observed that occipitofrontalis muscle is having attachment posteriorly and also bony attachment on either side. So blood cannot go further, but anteriorly it can go beyond the line of this scalp, and it is crosses the eyebrow and makes the black eye. Here I am showing by the red line, it is the median section through the mid part of the eye. You can see the eye in the middle part and the posteriorly, and above you can see the eyebrow. So blood passes deep to the eyebrow and enters into the upper eyelid. This is the upper eyelid, and also passes backward under the cover of the conjunctiva. So this blood causes a red stain in the eyelids, as well as also we can see the bleeding under the conjunctiva. This is the condition having black eye of both eyes. Deep to this, the deep, just superficial to the cranial bone, you can see the cranial bone, just superficial to it is the periosteum. This periosteum of the outer part of the cranial bone is known as pericranium, and this is the deepest layer of the scalp. This is tightly adherent to the. So you see the aponeurosis of the skull and the periosteum of the skull are very tough sheets, and in between there is a loose connective tissue layer, and this plane is having less blood supply, less blood vessels, but mainly the blood vessels are superficial to the aponeurosis or glia aponeurotica. So we can, surgeons can separate this scalp along this line deep to the glia aponeurotica, means aponeurosis, and can perform the skull surgery safely, and they can repair the bones or can do the brain surgery, and reposition of the scalp can easily be healed up because of there is no injury to the blood vessels or nerve. And after surgery there will be a good healing of the scalp because of the intact artery supply, venous drainage, and as well as sensation will be okay. So far we have seen some form of bleeding, like if the bleeding is from the outside, the second layer, this is loose connective layer which is lobulated in appearance. So if the bleeding is there with intact skin, then there will be a swelling, a hard swelling, and if the bleeding is under the aponeurosis but outside the periosteum, the bleeding will be diffuse and the swelling will be very less, but afterwards the patient will come with the black eye. If the bleeding is under the periosteum, the bleeding will be less because of very tight adherence of the periosteum to the bone, and the swelling will be very shallow. Artery supply of the scalp. Scalp artery comes from down to the vault from all directions. From the anteriorly, this is the supratrochlear artery and this is the supraorbital arteries. From the side, these are the branches of superficial temporal artery. And behind the ear, it is the posterior auricular, and this one is the occipital artery. So the anterior two arteries are the branches of internal carotid artery, and the posterior three arteries are from the external carotid arteries. The vein follows the blood artery. You see the veins coming from the towards anteriorly, towards lateral, and towards posterior. So the veins draining from the anterior part are the supratrochlear and the supraorbital vein. They unite together to form the angular vein in the anterior part of the face, and it continues as the facial vein. From the lateral side, all the veins unite together to form the superficial temporal vein. From the posterior part, the veins are drained into the posterior auricular vein or to the occipital vein from the most posterior part. All this vein from the posterior part drains into the external jugular vein. There is no lymph nodes in the scalp, but lymph vessels originates both in the different layers of the scalp, superficial layer and also deep plexuses are there. All the vessels, they converge to the lymph nodes present in the face and the neck. You can see in the face we have the parotid and buccal lymph nodes, and at the junction of the head with the neck we have submental, submandibular, mastoid and occipital group of lymph nodes. They receive the lymphatic vessels from the scalp in their respective sides. Nerve supply, the scalp anterior part, anterior to the vault, is supplied by the three branches of the trigeminal nerve. They are ophthalmic division, maxillary division and mandibular division. The areas are outlined by some dot lines. Posterior area is supplied by the second cervical nerve. Thanks for remaining with